Well, hello, everyone. Let's get started. Welcome to today's webinar, Telehealth and CBT for Psychosis, which is sponsored by the National Mental Health Technology Transfer Center Network. I'm Dr. Lydia Chwastiak. I'm a psychiatrist and a professor in the Department of Psychiatry at the University of Washington School of Medicine in Seattle, and I'm a co-director of the Northwest Mental Health Technology Transfer Center. Today's webinar is the second part of a four-week learning series. So the second part of a four-week learning series on clinical innovations in telehealth. And this webinar series targets high-priority clinical issues for clinicians using telehealth to provide treatment for behavioral health disorders. The series is a collaboration among several of our MHTTCs, and I'd like to acknowledge our partners who have worked to develop this series and make it widely available, including the South-Southwest region, Mid-America, Mountain Plains, and our National Hispanic and Latino Center, and also our network coordinating office. We had a terrific first session last week, and you can find more information about the series on any of our websites. The MHTTC network is a national network, was established in 2018, and it's supported by the Substance Abuse and Mental Health Services Administration, SAMHSA. Its purpose is to support the behavioral health workforce to disseminate and implement evidence-based practices for mental health disorders. Our Northwest MHTTC is based at the University of Washington in the Department of Psychiatry, and we provide training and technical assistance to HHS Region 10. The goals of our Northwest MHTTC are to ensure availability and delivery of free, publicly available training and TA to the behavioral health workforce in Region 10, to heighten awareness, knowledge, and skills of the workforce to address the needs of people with mental illness, to accelerate adoption and implementation of evidence-based practices for mental health disorders across Region 10, and to foster alliances among culturally diverse groups in the region to inform mental health treatment and policy. So without further ado, it's my great pleasure to introduce today's speaker, Dr. Sarah Kapelovich. She is an assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington School of Medicine, where she holds an endowed professorship in cognitive behavioral therapy for psychosis. She directs the Northwest CBT for Psychosis Provider Network and is a founding member of the North American CBT for Psychosis Network. Before she gets started, I'd also like to introduce the moderator for our Q&A session, Dr. Jessica Mora, who is also a clinical psychologist in our UW Department of Psychiatry, and whose work also focuses on CBT for psychosis. So at this time, I'll turn it over to Dr. Kapelovich.
Thank you so much. I am so excited to be here with you, and I want to thank the National Coordinating Office and the Northwest MHTTC for inviting me to talk on this topic. This is my professional passion, and it's really my hope that I'm able to impart some skills to ready you all to be able to do good work with your clients through the remote delivery of cognitive behavioral interventions. So our key objectives for today are to identify some of the main drivers of psychotic symptoms during the COVID-19 pandemic. I'll be walking through some high-yield strategies that are amenable to remote administration of CBTP or CBTP-informed care, and discussing evidence-based and evidence-informed digital augmentation services for this population. Now, telehealth has a lot of benefits for administering CBTP, some of which I'll review briefly at the start of this presentation. But one of the drawbacks is that there's a bit more uncertainty in terms of that uninterrupted time that we have with our clients. So in developing this webinar, I included interventions that are some of the quicker and easier interventions to administer in a tele-CBTP session. These are techniques that don't presume a full course of formulation-based CBTP, and also those that don't necessarily duplicate what we can provide to our clients using mobile health applications. And I'll review some of those with you today. So these are meant to be practical, off-the-shelf strategies. There's a long list of what this webinar will not address. I only had 30 minutes with you for didactic. And so if you are looking for an orientation to cognitive behavioral theories or therapies, I would direct you to the Academy of Cognitive and Behavioral Therapies or the Beck Institute, which have fabulous online training programs. If you're looking for an orientation in CBT for psychosis, I have a 1-hour orientation that I did about a year ago for SMI Advisor, as well as a free 3-hour primer e-course, self-paced, that's available through the Northwest MHTTC products page. And then if you're looking for more individualized or even in-person or web-based intensive training, you can visit the North American CBT for Psychosis provider network for information and training resources. And then to supplement this webinar, my team and I at the University of Washington have put together a number of resources. You're not meant to be able to read these, so don't try too hard, but we can put the link into the chat box for these free resources. There are clinical tip sheets for tele-CBTP for clinicians, as well as resources that we've put together for family members and caregivers, as well as individuals with serious mental illness and mental health providers. So one of the things that I love about cognitive behavioral therapy is that it centers on helping people develop new, healthier habits by breaking patterns of behavior that are interfering with people's values and goals. What we have observed in the past couple of months is, without a doubt, the biggest transformation of our country's mental health system since deinstitutionalization. And it's broken a pattern of brick and mortar healthcare delivery that was not meeting our collective goals of reaching our most vulnerable and our highest need population. We know that only 1/3 of people with psychotic disorders are accessing mental health care. We know that that figure is actually in the teens for people of color with serious mental illness. And that of that 33% of all Americans who do have access to mental health care, only 10% are receiving an evidence-based treatment. In 9 weeks or so time, we have seen a seismic nationwide adoption of digital mental health technologies that's going to allow for greater penetration of evidence-based treatments like CBT for psychosis. So many of us have climbed quite a steep learning curve to get to this point, but I think it's safe to predict that we are not returning to business as usual when the pandemic subsides. And this is to the benefit of our clients. It is abundantly clear that the e-mental health genie is out of the bottle, as my colleague Dror Ben-Zeev phrases it in his upcoming commentary in Psychiatric Services. And we're going to continue to see a quickening of the pace with which new, improved, and user-informed tools for people with serious mental illness are developed. At the end of this presentation, I'm going to share with you some mobile health and health tools that are currently available for our clients with serious mental illness, and those that are in the development and testing pipeline, so we can expect them in the near future. It was almost to the day a year ago that my colleagues and I at the Bright Center here at University of Washington published an article called Technology Assisted Life of Recovery from Psychosis, in which we chronicled a hypothetical day in the life of a young woman in the early stages of a psychotic illness, and all the different ways that technology facilitates both her treatment, but also her life as a young woman who can use digital assists to practice everything from reality testing to staying connected with her friends. And at that time, it was a vision that may well have been knocked as psychological science fiction, but this is the reality that we are moving toward. So we're witnessing practice catching up with the research, right? We know that telepsychiatry, encompassing both phone delivered and video conferencing, is feasible and acceptable to to individuals with schizophrenia spectrum disorders. And in fact, 90% report that they would use telepsychiatric services if offered to them. And we're seeing that, right? We're seeing that in practice. We're seeing no-show rates are low. We're seeing acceptance of telephonic encounters or video-based encounters is high. Importantly, when we talk about tele-CBTP, The therapeutic alliance does not appear to be affected when individuals are receiving it via telephone or via in-person sessions. And this was a finding that came out about 6 years ago. So that's really important for us to be assured that we can maintain a good therapeutic alliance with our clients when using these modalities. And emerging evidence points to improved client outcomes as well. Now, we know that CBT relies on an identified interventionist, and this is most commonly a therapist, but CBT works best as a team sport. The CBT way of thinking about how problems develop and are maintained has really become the dominant approach to understanding all forms of psychopathology. And CBT skills can be leveraged by all members of the team and by natural supports. And so this has always been best practice. But what we're seeing in Washington State through our Psychosis Reach initiative, in which we have trained family members in CBT concepts and skills for psychosis, is that it's led to some profoundly therapeutic experiences between family members. So the CBT therapist gets maybe 30, 50 minutes a week at best with someone. But when we can add in all clinical team members plus natural supports, and we're all talking the same language, reinforcing and rehearsing the same skills, and then add on-demand mHealth applications, the individual now has 24/7 access to CBT coaching and cheerleading. Okay, let's talk about key targets during the pandemic. And I want to preface this with 2 disclaimers. First, what we're noticing, and you may be seeing this in your own caseloads, is that there is a range in responses that we're seeing among clients with psychosis during the pandemic. When I checked in with the CBTP providers in the Northwest Provider Network, almost all of the clinicians reported that many of their clients were doing the same or better than they were before the pandemic. So I think it's important to recognize that what may be new to some of us is the norm for many of our clients, unfortunately. So isolation and inactivity is often the norm for so many of our clients. Not having a routine and structured activities is a norm. Living in fear and uncertainty is a norm for many of our clients. That being said, a lot of our clients are really feeling the stress, either of the pandemic itself or of the economic and social fallout. And we know that this unmanaged or poorly managed stress can significantly exacerbate psychotic and mood symptoms. The second disclaimer I want to give is that these are sort of some targets that should be on your radar, but really this needs to be individually formulated for each client, right? So you'll want to be attentive to these. Are these the same, better, or worse for each of your clients? Because we know that these are often main drivers on a population level of psychotic symptoms, but you need to do that assessment to really determine what's going on with your client right now, knowing that many of our clients, actually many of all of us, when we're under stress, we revert to former habits and behaviors. So for all of these targets, we're going to focus on the same kinds of skills, but knowing that there is this CBT process in everything that we do of engaging the client, assessing the problem, using intervention strategies, and then ensuring that the individual is able to practice these strategies independently so that they can sustain gains. So here's the list of the telehealth conducive CBTP strategies. The ones you see in brackets, I won't explicitly be covering. These are these are very well covered actually in a number of texts. The one that I often refer clinicians to is by David Kingdon and Doug Turkington, Cognitive Therapy of Schizophrenia, published in 2005, and they document very nicely befriending strategies, psychoed, and normalization. With you today, I want to focus on the cognitive strategies, behavioral strategies, and then digital augmentation. So let's kick off with cognitive strategies, and this is going to be a bit of a skills blitz. So feel free to type those questions into the chat box so we can cover them when I finish. So where do we start? In CBT, I think we hang up our assumptions and we use Socratic dialogue to explore our clients' thinking, feelings, and behaviors. COVID may or may not be on their radar. It may or may not be the source of their distress. And if it is, their COVID-related concerns might be quite different than what we might be experiencing ourselves. So we assess rather than assume, and then we try to make sense of those automatic thoughts that are coming up for our clients based on what we know about them, sort of how they see the world more generally and how they see themselves as a player in that world. Now, in psychotic disorders, there are a number of different information processing errors that happen and reasoning biases. The number one most common reasoning bias that we see in individuals with psychosis is called jumping to conclusions. And that's where they're forming a decision about what's going on before they get all the information. And once they form that conclusion, they don't really deviate when they don't look for new information, they don't process new information, and they don't account for that new information when it comes up. We're all guilty of jumping to conclusions. It happens more commonly in individuals with psychosis. So the issue here is that when we have these sort of paranoid type interpretations or derogatory type interpretations, that what happens then is we are more likely to notice the negative, we're more likely to interpret things negatively, and we're more likely to remember the negative. And of course, that then primes us for more negative interpretations. And now we're in this negative loop, which is just a breeding ground for delusions, anxiety, and depression. So the antidote for the jumping to conclusion bias starts with alternative explanations. And what's interesting is we're seeing some neuroimaging studies of people receiving CBTP, and it's indicating that we can literally change the way that the brain is functioning. And in particular, over time, we can tamp down the overactivation of the threat system in the brain. And one of the ways that we do that is to help people be more flexible in their thinking and to fundamentally change the nature of their relationship with their thoughts so that they begin to treat each thought as a hypothesis. This is a starting point, not the end point. And I think the other thing that's really important to note here is that generating alternative explanations is highly linked to problem-solving abilities, which we know is another area of need for our clients. And so, right, our effectiveness in problem-solving hinges on our ability to identify the problem and generate possible solutions. So when we're doing this work with clients, we want to treat this as brainstorming. We're not looking for what's the right answer, what are wrong answers, or even at this point, how likely, but just how many different interpretations are there of this situation, and we're going to help sort of facilitate that mental flexibility. The second is practicing rational responses. And a simple, repeated, rational response can do wonders to get folks through a tough moment. This is, when our thinking brain goes offline, something that we have rehearsed that comes very easily to us and that provides comfort and assurance. So I'm working with a client, I just started with her, we've only had about 5 or so sessions, and a couple of weekends ago, she was in a suicidal crisis. The voices were telling her, you need to kill yourself, you're supposed to die. And we created a safety plan, very much in line with what Dr. Stanley had guided everybody in the clinical series last week. And on that safety plan, we put on the rational responses. Just because you said it doesn't make it true. And I can't control you, meaning the voices. I can only control myself, and I'm going to stay safe. So these were really simple, easy, that she could just say to herself over and over like a broken record to get her through that tough moment. Okay, let's talk about meaning making. So our brains are meaning making machines, but we also have learned over time how to let some things go that's just noise and not stimulus. Our folks with psychosis have a difficult time separating those two. And so there's meaning in everything, right? So there's meaning in the flickering streetlight across the street from the apartment, right? There's meaning in the dead bee that's, in your path as you're walking. And so we want to try to help channel this from ideas of reference into productive and adaptive pursuits. And where we start with this is twofold. One is helping the individual identify their values. What is important to you? So that we can help them to generate some activities that they can pursue come COVID or high water, right? And then when they act on those values, they're able to start sort of take back some of that control. And this is really sort of the cognitive side of the behavioral activation coin, right? Taking them from engaging in contributing and value-informed behaviors to making cognitive shifts about what those behaviors say about them and their ability to manage a crisis. And this brings me to my second point. They have a lot more experience than many of us do in loneliness, in isolation, in boredom, in feeling worried or paranoid, in being attuned to all of the different bodily sensations. And so I might have a conversation like, how can you cope better? How can you help others in your life cope better with these experiences, which may be very new to them? What have you learned that you can help teach somebody else to coach them through this tough time? And what does it say about you that you care about this? And then with regard to those values, right, how do we take those values and help you use this time to your advantage so that you can pursue those, you can live a value-driven life and pursue those goals? Okay, so the payoff matrix is also called a decisional balance, and it allows you to look together at how the belief is functioning for the person without having to get into a discussion of how accurate the belief itself is. It's more a matter of in what ways is this belief helpful, and in what ways is it not helpful, and in what ways would altering the thought be unhelpful, and in what ways would altering the thought be helpful. And from there, we can help the person to maximize what it is that they're looking for, right? Maybe it's feeling safe or feeling needed and respected. We can uncover that together, oftentimes using a payoff matrix around some tightly held belief and work toward those positive feelings. Okay, so we do a lot in CBTP. A lot of what we do is some form or other of reality testing. So checking things out, probing around the edges of some firmly held belief, all the way up to doing experiments to test out our beliefs together. The form that reality testing takes in tele-CBTP really depends on what stage of therapy you're at, the state of the relationship, and how much of this reality testing you've done so far. So the person's mastery over these kinds of exercises up to this point. Our main tool is Socratic dialogue. So again, that non-judgmental, curious questioning, things like, how does that work? Who does that apply to? Who decides who has a power like that? Or, who gets COVID and who doesn't? How is this studied? Who's studying it? What are some information sources that are reputable? And what makes for good quality evidence versus poor quality evidence? Now, reality testing can be tricky when it's done via telehealth. And so you really want to make sure that you know your client well when deciding how and whether to proceed, and go with that lowest hanging fruit first. So you can ask them, how much do you believe this? 0 to 100%, and see where they're at on that scale. And how distressing is it to you, 0 to 100%? And then you're not going to start with something that's 80, 90%. You want to start with like, oh, I'm not sure, maybe, I don't know, maybe 60%, and start to explore those shades of gray or areas of gray. Okay, so let's shift to our behavioral strategies, and we're going to start with the stress bucket. Because one of the things that I frequently hear from clinicians is, how can I talk about these things with my client when they don't agree with their diagnosis? And the stress bucket is a beautiful way to build motivation to work on stress sensitivity, stress mitigation strategies for all of our clients. And the analogy here is we can think about our capacity for tolerating stress as a bucket, and we're each born with our own sized bucket. Some are large, some are small. The water that comes into the bucket is our stress. So that might be hearing voices, it might be a mean boss, recent unemployment. And we can't control all stress, of course, but we do need to get this water out of the bucket somehow. And we each have these release valves. Now, the release valves are coping strategies, and you can see some of the coping strategies are effective because they take water out of the bucket, and some only work temporarily and ultimately dump back into our bucket. So working with our clients, we can find out what they do now that takes water out of the bucket, and what do they do that helps temporarily but makes things worse, like screaming at the voices. And then we can teach them new coping skills for their stressors, and we can use YouTube videos, websites, mHealth apps to help them rehearse these skills in vivo. There was a great article in the Wall Street Journal. I forwarded it to my family this past week, and it was called The Healing Power of the Breath. And it is really preaching what Eastern medicine has known for a long time and Western medicine is just catching up with, which is that proper breathing can do wonders for your physical and mental health. And so paced breathing is a very simple strategy that we can teach our clients to treat both chronic and acute stress. We want our clients to start practicing paced breathing twice daily so that they can get into the habit of this and also start to blunt some of the anxiety and depressive symptoms and psychotic symptoms through this practice. And also they can use it during an acute stressor when they've rehearsed it and overlearned the skill. And the two key techniques are that your out breath needs to be longer than your in breath, and that you're taking breath in through your nose and pushing it forcefully out through your mouth. Okay, activity scheduling. Activity scheduling is, we know, a component of behavioral activation, which is an evidence-based treatment for major depressive disorder, and a core component of CBT interventions for negative symptoms. It also happens to be one of the most important things that all of us can do during uncertain times and can help break the perseveration on thoughts, physical sensations, perceptions, and emotions that might be fueling delusions or other strongly held beliefs. There are certain things that we can do just in our clinical practice to help clients start to have more structure, routine, and predictability throughout their week. One of those is, if you can swing it, just to alter your schedule so that you're meeting with your clients for 2 15-minute sessions, 2 or 3 15-minute sessions, rather than 1 30 or 45-minute encounter. This improves accountability and it ensures more structure and consistency to their days. Now, typically, we talk about mastery and pleasure as the two most important types of behavioral activation. But in this case, we want to be thinking about these 7 categories. Now, obviously, there's going to be some overlap here, but it's critically important that in addition to helping our clients formulate activities throughout every single day that will promote joy and feelings of success or mastery, that we are also collaboratively identifying activities that will promote connection, because that connection is the antidote to isolation and feelings of loneliness. And loneliness is like gasoline on a psychosis fire. So we really need to facilitate this connection. The resource guides that I'm making available have some national virtual community suggestions on there. There are a ton of other ones that I think are coming up spontaneously in your regions. Contributing activities, there's a tremendous amount of literature from positive psychology on the mental health benefits of contributing and altruistic behaviors. And so what does the person want to do, and what are they capable of doing right now to help feel like they're doing something to help? Physical activity we know is absolutely critical. And then many of our folks with psychosis are just wells of creativity, but limit their creative engagements because of self-criticism. And so what are some ways that we can help to encourage them to re-engage in their creative pursuits and passions? And then delusion diffusing categories is when we go through that payoff matrix with our clients, oftentimes we learn so much about the function of some of their strongly held beliefs, right? It gives me a sense of safety and control. It makes me feel like people need me, and we all need that. And so how can we help the person identify activities that will meet that same function? We know that disrupted sleep is a precursor to symptom relapse, and so it's critically important that we are assessing for the health of our clients' sleep practices, and we're making modifications that will promote good quality sleep and a daytime schedule. So there are free resources available on the website listed on this slide, and I would say in particular, we really want to have, just as we have a safety plan for our clients with suicidal ideation, we want to also have a sleep plan for our clients with disturbed sleep, where we're identifying coping skills that they know very well and can use at night, because we know that oftentimes symptoms are reporting as being at their highest in the evening hours. Okay, we're going to end on some CBTP tips, as well as mHealth and other digital augmentation strategies. So many of the platforms that are being used to deliver telehealth have a whiteboard feature. So Zoom is one of them, and CBT is big on multimodal learning. And so we will write things out, our clients will write things, we'll diagram, and so we can use that whiteboard function when we're sharing screens with our clients, so we still have that capability. When I see clients in person, I'm having them fill out some assessments in the waiting room before I see them. And so in lieu of that, we can send some assessments through the electronic health record or through encrypted email, so our clients can fill those out before session, and we're not taking up that valuable session time, particularly when we might not have a stable connection. And if you can, I'd highly recommend use of a data dashboard to help clients visualize progress and account for change. This is the insight that matters, right? At the end of a course of CBTP, the kind of insight I care about is, this is what makes my symptoms worse, and this is what makes it better. And we can get that by using data visualization tools. So this is just a screenshot of one that I use with my clients, and I administer regularly for clients I see who hear voices, the Beliefs About Voices questionnaire. This is a client that I was treating between April and January. We terminated, and at the end of January, he was doing very well. He had gotten you could see his resistance subscale had always been the highest, and we were able to get that down. And the product of that was, he was back at school, he was working part-time, he was volunteering at a church. So we terminated, and he was able to maintain gains even through a medication change. When the pandemic hit, he started to become a little bit more distressed by voice hearing and thought broadcasting. And so we scheduled monthly booster sessions. And you could see in just a couple days ago, we reassessed BAVQ, and we could identify what was causing him to feel more distressed. It was, he was engaging in more unhealthy behaviors in response to the voices, these resistance type behaviors. So we were able to, I've been able to treat to target, right? We can use those booster sessions far more strategically now. Okay, I want to show you first what is in the pipeline in terms of psychosis-specific mobile health applications, because this all portends a really exciting next couple of years for our clients with early and persistent psychosis. We have mHealth products that are in the R&D stage, some that have already completed feasibility testing, and others that have already completed the randomized clinical trial, so are closer to getting to market. And then we have a few apps that are commercially available. So Focus is the most well-researched mHealth tool for clients with SMI. I'm collaborating with the developer of this tool, Jor Ben-Zev, on the first, in fact, Lydia and I both are the first implementation trial of an mHealth tool for people with SMI. And if you visit the mh4mh.org website, you'll be able to get some updates on when Focus will be available to people, by download. New from the Sussex Voices Clinic in the United Kingdom, we have the Choices app, which is meant to be an accompaniment to the Overcoming Distressing Voices book. That is a guided self-help book for people who hear voices. And then we have some tools that are all CBT informed tools that were not tested on our folks with serious mental illness, but you might find helpful, especially in reinforcing some of the skills that you'll be doing with them. And then my team, and this is largely the product of my research coordinator, Jennifer Blank's efforts to not just identify the mHealth apps that are commercially available for download, but actually test them and make sure that they work and are real. And she's put together this mHealth app to help, mHealth guide to help each of you either to use as a handout or just for you to refer to. Okay, that's all I have in terms of prepared content. And I think I have a sticky note saying stop by 10:40 and I'm stopping by 10:39. So I think I've been good to my word. So I'm gonna go ahead and shift things over to Dr. Mora for Q&A.
All right. Thank you so much, Dr. Kovalovich, for a terrific presentation. I think this is such an important and timely topic, and that's pretty evident when looking at the great questions that all of you have posted in the Q&A board. Thank you for those questions. So on that note, Sarah, I'd like to highlight a few questions that have been posted today. The first question we have is, can you give more specific examples of using reality testing with a client with psychosis?
Yeah, so I want to acknowledge I'm using the term reality testing quite broadly, right? So this could actually look, again, kind of depending on where you're at with your client, this could look a lot of different ways. So one form of gentle reality testing is simply using our Socratic dialogue to try to kind of model curiosity, model this benevolent curiosity for our clients. So it's that, how does that work? And have you, when did that first occur to you? What was going on in your life when that was happening? Just to start to plant some seeds that maybe there were some other things going on there. But we're not challenging the client, right? We're never disputing. We're never getting into a tug of war about people's beliefs because those are counterproductive. They don't feel good and they don't affect the kind of change that we are hoping for, which is, to help the person feel better. So that's kind of where we start in reality testing. And then we want to ask them, what are some ways that we might learn more about this? So we wanted help by modeling that curiosity. We're hoping to make the person feel more curious about these ideas that they have and how they were developed and what has maintained them. And so we want to ask the client to identify what are some sources that you trust, what are some sources that other people turn to when they're looking for credible information on something. Can we do some of that research together, or can we do it independently and then report back together on what we found? So checking in with people of authority or credible sources, scholars, practitioners might be a next kind of place that you would go. And then you want to kind of build up to actually starting to test out some of the beliefs. And this is really critical for moving somebody from cognitive change to behavioral change, right? I can, in session, when I'm kind of calm and I'm using my prefrontal cortex, I can think about all these different explanations, and I can even decide, yeah, maybe this isn't the most likely one, maybe this one is just as likely, if not a bit more so. But when I'm emotionally activated, man, that first explanation that's going to come to me is that one that's been most, front and center all along. And so Dr. Beck talks about that, emotion is really the crucible of change, right? That's where change happens, is when we can activate someone's emotion. And that really comes with what I call the capital R reality testing. That is going with somebody, or even virtually, being able to test this idea out in a safe way. And this requires more kind of clinical finesse and acumen and forethought about how am I setting up this behavioral experiment? How are we going to test it out together? How are we going to reflect on what we found so that we can make sure that this is a therapeutic process? But really the idea here is that we're going to identify that belief, and we're going to test it out in partnership together and debrief on what we found.
Thank you. That's a great distinction. I have another question that has come up a couple of times that I think is a really good one. How does telehealth work with clients who start therapy without meeting you as a clinician? And how can you get them to trust you to start treatment? Does this affect the therapeutic alliance if they're having auditory hallucinations?
That's such a great question. And I've had the experience since the pandemic hit of seeing clients for booster sessions that had terminated, seeing ongoing clients, and then starting with clients anew. And, every client is an individual. And so your process, your mileage may vary client to client, but the experience that I have had has been consistent with the literature, in that I have not found there to be profound poor engagement, lack of engagement, or poor alliance with my clients who are starting new with me via telehealth. Now, I will say clients that have delusions that are specific to surveillance and technology are going to struggle a lot more with this modality, and many of them may just refuse to engage. And so that is certainly a limitation. And, there's one of the papers that is actually referenced on this slide, the second of the two papers, talks about different strategies that you can use that are all COVID-19 friendly, that, where you're not necessarily having to do this video conferencing technology. So for those clients, I would say, let's look at some other options. But for the most part, I found that people have been able to engage really effectively via telehealth. And I'd actually considered putting in some testimonials that I'd gotten from my clients about telehealth. I didn't have the kind of time in the presentation, but one of them called it her lifeline, and many of them found it to be quite effective.
Awesome, thank you. And kind of on that note, we had a question about specific strategies to handle paranoia through telehealth. And so I wonder, it seems like that paper might be particularly helpful for this person, but I was wondering if you had any initial thoughts or additional areas that they could look into.
And it was paranoia specifically around technology?
Just for decreasing paranoia, it looked like it was persecutory paranoia, but just through the telehealth modality.
Yeah, I mean, I will say my personal experience is if you can get in a 30-minute session via telehealth, even it's a little bit more challenging and more constraining when you're working via telephone. But certainly if you're doing video-based encounters, I have not felt constrained to address paranoia in the same ways that I do when I'm working in person. And I think just the caveat, just not knowing exactly the nature of the paranoia that the person is asking about. Again, if it is with technology and surveillance, then we want to be able to offer them other ways so that we don't, so that we have a client to work with, so that they're willing to come and meet with us. But again, trying to assess what's fueling the paranoia, what's driving it. And I listed on that key targets is that, we know that when we have sleep disruption, our thinking is less clear, and just skews more suspicious, paranoid, or depressive or anxious, right? Naturally for all of us. And so we want to address that. We want to be addressing the things that are really fueling this person's paranoia, depression, anxiety, in the same ways that we would for CBT, where the depression, anxiety are our targets. And then using our cognitive and behavioral strategies, which I've started to introduce today.
Thank you. We've also had a couple of questions about how to adapt these strategies for teens or children, or also families of a child who experiences psychosis. If you had any thoughts on that, or perhaps a resource that people could look into that you're aware of.
Yeah, absolutely. So the indication from the literature is that CBTP is effective for adolescents who are experiencing either a first psychotic episode or seem to be in a clinical high risk state for psychosis, where they might be experiencing, magical thinking or some psychotic like symptoms. And that we know that CBTP can even help to prevent the transition to a psychotic episode. So I would be thinking about the same intervention package, preferably a formulation-based CBTP, but even if you're just able to start introducing some CBTP skills and psychoeducation, a lot of normalization, that this can have a tremendous therapeutic effect. And normalization for children and adolescents of psychotic-like experiences is key. We actually know from epidemiologic research that psychotic-like experiences like hearing whispers, seeing things in shadows, having concerns that other people are watching us or mean to harm us, that those are actually quite common in the general population. And when we can normalize these experiences, particularly for our young people, that we can help prevent some of the catastrophization that actually fuels the paranoia, fuels the voices, and makes them more likely to experience a psychotic episode. So those are going to be among our high yield interventions for children and adolescents experiencing psychotic or psychotic-like symptoms. And then for family members, I'm so glad people asked that question, because this is sort of a newer area for me, where I've partnered with a colleague here, Maria Monroe-DeVita, a colleague at Stanford, Kate Hardy, and one of our CBTP treatment developers, Doug Turkington, to develop a training protocol for family members in CBTP-informed skills. And it's called Psychosis Reach. If you go to psychosisreach.org, you can see our slides, you can see some videos demonstrating what these more therapeutic family interactions look like, and you can get information on the Psychosis Reach 2020 event.
Great, thank you. We also have a question about liability-related issues that need to be addressed when using telehealth.
Well, so that's a topic that is much more repletely covered, in many other webinars and websites online. There's also some regional variations that people need to be mindful of. This is, from a liability perspective, we're treating medical necessity. And so you obviously want to be documenting risk status, you want to be documenting substance use, you want to be following good clinical guidelines in terms of assessing, documenting, and managing all forms of risk, grave disability, risk to self, risk to others, and risk of victimization. But there, no kind of particular, I think, liability issues outside of those that I would want to caution people about related to CBTP specifically.
Great. And we have another question about, you were speaking about behavioral activation for a moment. A few clients have had questions about how to get clients motivated through telehealth, particularly when they're experiencing a lot of depressive symptoms or have disrupted sleep patterns.
Yes, fantastic and very understandable question. Behavioral activation is one of those things that just looks so easy. You just got to get your clients to do this, but we know changing behavior is very, very difficult. So I have a whole didactic on that And even that is not enough. We could do a 3-hour series on in behavioral activation alone. But because it is so critical, I will say this. I think that one of the most important ways that you can get more bang for your buck with behavioral activation is by doing the work at the front end to identify what's important to your client, and not in terms of their goals. Oftentimes we talk about goals and people have, especially if they've been in the mental health system for many years, they're just goaled to death. Ask them about their values. Do a values exploration exercise. When I was working, this client that I mentioned earlier, who has struggled with chronic suicidality for over a decade, and I asked her about, what do you hope to get out of treatment, which is, a subversive way of asking her about goals. And she started tearing up. And, when I asked her what was going on, she said, I don't know about goals. Like, I don't even know if I'm going to live to tomorrow. So it's hard for me to talk about goals. So we took a step back and we did a values exploration exercise through screen sharing. And we identified really what's important to her, and then started to come up with just what is she doing now? And what's one thing that she can do that's in line with one of her top 4 values. And for her, it was connecting to other people. And so we were able to start getting her connected to her friends again.
Awesome, thank you. And do you have time for one more question? I know we're about to shift, Lydia.
Yeah, no, go ahead, Jess.
Okay, we have one more about any specific thoughts for online or community group recommendations for those who experience psychosis, since a lot of clients are unable to attend in-person groups.
Yeah, so in my home state in Washington, we have part of our provider network, we have a specific group of providers who've been trained in group CBTP, and we are helping work with those agencies to get as many of those groups to be offered via telehealth as possible. We had Tanya Lecomte, who's at University of Montreal, on as a guest speaker several weeks ago, and that's a recorded didactic. I'm happy to make that available. Actually, that is available on the Northwest MHTTC, I think it's on the resource page, where she talks about how she's been facilitating these groups via Zoom for a couple of years now. So she talks about her experience with it. Outside of CBTP groups, the Hearing Voices Network has several chapters across the United States, and they have moved their in-person meetings online. And so you can Google Hearing Voices Network and see whether there's a group that's meeting online in your region.
Great, that's terrific. Thanks to you both. Third in our webinar series, this is on providing culturally relevant telemental health services for Latinos during the pandemic. This is again June 9th, and on June 9th for the telehealth treatment of PTSD. So the last 2 of our series, these are again every Tuesday, 10 a.m. Pacific time, 1 p.m. Eastern time. You can learn more about our MHTTC and register for additional training opportunities. On the next slide shows our website, www.mhttcnetwork.org/Northwest, where you can also sign up to receive our newsletter. You can also find us on social media or email us with questions. And the 13 centers that comprise our MHTTC network really share resources and training opportunities. And we have free self-paced online courses that are at healthyknowledge.org. So as we mentioned, Dr. Kopelevich's really terrific online CBTP course you can link to through the Healthy Knowledge website or through our Northwest MHTTC website. So I just wanted to thank once again our presenter, Dr. Kopelevich, for a really terrific presentation, and Dr. Mara for managing quite a busy Q&A session, and just thank all of you who viewed the webinar and just for taking time to learn more about this important topic. So we'll look forward to seeing you next Tuesday and the Tuesday after that for the rest of our series. Thank you all for joining us today.